Welcome to Vane University Grand Rounds and Talk Show. My name is Lowell Kadnick, and today we've got an exciting group of professors, and we're going to be talking about HIFU thermal. And our main leader today is Professor Stalnikiewicz, and our discussants are Professor Cassoni and Professor Elias. So if you would take it off, Guillaume, the floor is yours.
Okay, thanks a lot. I'm so delighted to be here. Thanks a lot, Lowell, for the invitation, and to Professor Kanata as well for having me at the VLU. It's the HIFU family gathering here, and I'm really happy to get together with Dr. Elias and Professor Kazani as well. So I will try to do my best to introduce you with the HIFU, what it is, what it makes, and how to perform it. Just a word of introduction. So I am a French physician, vascular physician, and I've been a laser guy over the last 21 years. And so I can say that I know what to expect from thermal ablation because I live in the ablative world. And so we're diving into the topic. So I have no disclosure. I always pay you tribute to my beloved master. Thank you, sir, again. And just a short historical review. I won't go through the whole details here. I guess the presentation will be available online. But just to highlight here the fact that there is a very short amount of time between the discovery of ultrasounds and the first medical attempt. And we're just following the path that has been opened to us by those physicians earlier. So what is a HIFU? You would do with HIFU exactly the same thing you would do with a magnifying glass, focusing the sunbeams to elevate the temperature. It's exactly the same thing. And you will move the magnifying glass along the vein to deposit the thermal energy onto the vein, but you do it from outside the body. There's nothing inside the vein. That's what makes it a little bit a Star Wars thing, I can say. And the idea is that you create an acoustic focus. This is not an optic focus, obviously. And on the top of this focus, where the intensity is maximum, you will, this is very basic physics, and I won't go too deep into that. When I increase the pressure, I will increase the temperature. So this is basic physics and mathematics as well. That's the way it works. Here you have a picture I took myself at Theracrean premises when I first met them in December 2019. This is chicken, obviously, and you can see that the surface is completely neat. There is no heating going on, and you can see this course of 6 pulses really neat inside the chicken. Bear in mind that this is proteins. This is 100% target here. It will be quite different in the real life because you will have the blood flow, of course, acting like a cooling system inside. So it's more challenging than just shooting meat with veins. So we share a common idea with laser and radio frequency. In the ablative world I live, Professor Kazuni is doing something different. And we do it from outside of the body. And if this is an office procedure, with or without local anesthesia, I do use a little bit of local anesthesia. We can go through that. And the great thing is that the patient can be back to work immediately. I mean, no time. I remember having a dentist in my office at 10 a.m. and she was treating in her own office at 1 p.m. So really easy, in and out patient. How it works? How do we create this beam of focused ultrasound? It's quite easy. It's quite magic. It's just the fact that the transducer is a portion of the sphere that creates the beam of focused ultrasound. It's as simple as that. The engineers will appreciate that. Of course, it's a little bit more difficult, but basically what you deal with when you practice is with this head you have on the right of the screen. You have a robotized head in which you plug the probe, and on the top of the probe, you can see the transducer. I will be back to this in a moment. And you have an embedded imaging system, which is ultrasound, and you mount a balloon onto it. The balloon will be filled with water. There are giving sets around it, and It has three purposes. First, it will, of course, allow the ultrasounds to travel through the water and to reach the skin and then enter the body for the imaging system and the focus of the ultrasounds. And it will cool down the skin. I will be back to that too. And you can modify the shape of the balloon when you fill it up with water under pressure to compress the vein, because to treat the vein, you have to compress it. You want the anterior and posterior wall to stick together. Here an overview of the device. So basically, you have a complete control of the head and the robotic arm. You can place it wherever you want on the patient leg. I will show you that later. And you have remote control on the touch screen on the left. Yes, it's just a basic anatomy of the device here. So this is how it looks like in my office. Welcome to my place. And I want to say a word about the transducer. The transducer is the main part of the device, and it really shapes the way you work. The fact that it is a portion of a sphere, it has a radius of curvature, and this radius of curvature will define the maximum depth you can reach, which is 24 millimeters. So we did a lot of measurements, and you won't leave a lot of patients behind. There is just one situation I want to outline to you. It's because it can be hurt. It can hurt your pride. It's fat people, because the grease, when you try to compress the vein, won't compress. It will just move down and you will see the vein vanish into thin air and you can't reach it. So it's just here to outline the fact that you have to have a very careful selection of your patients to respect the treatment range. So the maximum depth is 24 millimeters. This is not negotiable. So now about how superficial can the vein, can we treat superficial veins? We also have a limit, and it's quite easy to explain. Here, it's about the thermal relaxation time of the skin. Let me explain. You have the skin and the vein here, and your beam with the energy that has to go through the skin, and it will, a certain volume of skin would be involved in the energy. If the vein is a little bit higher, then the same amount of energy has to go through a smaller slice of skin, and you may burn your patients. Basically, that's what it is, because it needs some time for the skin to evacuate the heat and the energy that is going through. That's why you have a constant skin cooling system, which is the balloon filled up with cold water, 14 degrees, as far as I remember. The device will also monitor the distance from the vein you're trying to target to the skin, and will not allow you to give the full power of the device. Basically, if you're trying to shoot and the vein is too superficial, it will give you nothing. This is security for the patient. And you have to respect a mandatory pause to let the skin cool down. This is the TRT, the thermal relaxation time you have to respect. So basically, any vein above 9 millimeters should not be addressed. That's the point of these superficial veins. So you have to be very careful when you recruit your patients. Test positioning, and there is a study you remind me of in Venice, well, about very bad results of a French physician, because she did put every single patient under the device without respecting that range. And she could prove that if you don't respect the range, you don't have success. Basically, that was the result. So the minimum depth, you can deal with it a little bit for short segments by injecting water under the skin to push down the vein. Bear in mind that the more you inject, the more you tend to spread the HIFU beam and lose efficacy. So for the moment, the maximum depth is the maximum depth. Here, you are with me in my office, treating a patient. So you can see that we put the robotized head on the patient's leg with the and you will deliver the energy by just clicking the button pulse. I will go through a few things here about the monitor. You have on the left part of the screen white lines that we call slices. It's just like you would see the patient from above. You're the head, the robotized head, and you will click on these lines to go, and you will go downwards. But as you click downwards, the head moves horizontally towards you. So you will go along the vein. Each slice is separated by 3 millimeters, and you will have to deliver as many pulses as necessary related to the diameter of the vein. The arrows you have on the right side of the screen are used to go right, left, up, down to really target the vein you want to treat. So here's an example of a pulse, and we will go through that. So you have the 7 seconds pause, then 3 seconds to load, and then a 0.5 second pulse. You click and the head moves down, and you do the pulse again. I will play it for you once again because I just would like to explain you what it takes to deal with HIFU. So just watch out what's happening on the vein here. You will see that it moves, it's the pressure, and you can see that only the anterior wall did react. You have these white bubbles on the top of it. I would say that here the physician did not very well because the heat tends to go up and not to go down. So here the calipers should have been put a little bit under the vein, so you make sure that the vein the energy is on the bottom of the vein and will go up, and you will then treat the anterior and posterior wall. Here you did treat the anterior wall and the fascia, in fact. So it's just to outline the fact that you have to learn a new semiology when you treat. It's not just pushing a button and targeting a vein. Some results to show you what we can do with it. I treat truncular extensive part of the veins. Here, a great saphenous vein of 6 millimeters, and just after 6 months, you can see that we can achieve disappearance of the vein. It was in 2021 or 22, so very early in my practice, we were working with the 8 and 4 second pulses. It used to take us a lot of time. Here, a perforator. All the perforator I did treat are the ones I couldn't really address with laser because I've been doing laser on this for years. Here, it's a recurrence after stripping on the leg. Here, it's another perforator from the popliteal area after stripping again from the short saphenous vein. You have the results after 1 year. Another leg perforator after 8 months. It's now 3 or 4 years for this patient, and the vein completely disappeared. Here is one of my favorite cases, Giacomini. I live in the ablative world, but I'm a little bit into hemodynamics as well. And there was a strong reflux on the Giacomini with a siphon effect on the great saphenous vein and a reflux going inside the short saphenous vein. And when I did compress the Giacomini, the reflux did disappear on great and short saphenous vein. So I did treat the Giacomini with HIFU because the patient didn't want to enter an operating theater. And you can see the results after 6 months, and it was quite a big one. I did use a little bit of tumescence here, not just local anesthesia, because I really had to shoot hard. You can also address stumps. I try to, I won't say smart, but to trick a little bit the thing here, I treat it on the top and the bottom and foam in the middle. And gave me some good results to lower the pressure inside the stump and make the foam sclerotherapy to be more efficient, I guess. It's just a guess. So what do we have here? Some long-term results. I have now patients treated 5 years ago, complete disappearance of the vein, and of course, no recurrences. You have a knee perforator after 2 years here and a short saphenous vein. My success rate, there are 2 ages. There is before the 0.5 and 1 second in new imaging system, and the very beginning, we had to learn what not to do. And sometimes we were a little bit dejected by the results, and the patients have been very patient with us as well. But since 2022, I can say that every single patient I put under the device, I will close the vein. We have, their success rate is not 100%. That's okay. I have 1 patient, I did treat both great saphenous vein at the same time, but it didn't work. I still don't know why. 1 ESV, I could perform the treatment completely, but the pain management was quite difficult with the patient, and in the end, it didn't work. We did include it in the statistics. And short saphenous vein and perforator. Perforator, of course, I did address the one I could not address with laser or something else. So these are the challenging ones. The greatest improvement for physician, except the results over the last 2 years, has been the comfort we had from the new imaging system. It helped us to save a lot of time to treat a full grade saphenous vein 30 centimeters. It used to take me 2 hours and 30 minutes at the very beginning. Patient in, patient out. Now it's 15 minutes. So it's already a game changer for us. And that's what we expect now from the device and from Theracleon, is to provide us with AI to help us locate the vein, because it's not always as easy as you've just seen before on this pulse modulate demonstration, and to give us some comfort with the device. And I would say, when you expect from a technique to give you personal comfort, you did already achieve good results. That's what I can say here. And those results, you can have an idea through these clinical results that you can go through online with a lot of clinical studies now running. And this is it. Thanks a lot for your attention.
Thank you very much, Guillaume. That was wonderful. I'm now going to turn it over to Paolo, who's got very much of an experience with this, and comments and/or questions.
Thank you. Thank you, and congratulations, Guillaume, for your presentation. I agree completely, but I think there is something challenging in the philosophy, because the philosophy of ablation you can do with some vein, of course. You showed us you can do, we can do if you want, but I think that the hemodynamic approach is completely a revolution with the HIFU. Over that, I have to say that we presented in European Venous Forum a new experience, because in 22, at the beginning of our experience, in 22% of patients, I still see the vein refluent. So what happens in reality is that there is a stiffness of you get the stiffness of your wall, and the vein doesn't change the diameter from the standing position and in lying position. So what I mean that if you have a 9mm GSV in standing position, and when you treat in these 7mm in lying position, and you treat and you get 4mm after HIFU, and you see reflux, and you say that is a failure. For us, was a failure. It's not a failure. It's a completely different approach, because you have a volume hemodynamics, and the volume in your vein is less. And what we say is that the patient is good. Now we are starting with the photoplethysmography, and to see that we can really change our mind in phlebology in the future. But what I have to say is that we proved with histology if that the energy delivered from the HIFU, as you told perfectly, is from outside, is not from inside. With laser, you get the energy from inside, so you destroy all the wall. From the outside, you can destroy all the wall if you want, but the endothelium is incredible, because it can regenerate very quickly. So what you seem to have a recanalization is not a recanalization, because you have a very, very small flux inside the vein, but the vein is functionally closed. What is interesting to do in Shiva method, I see in the audience Capelli, that it's very expert in this hemodynamics, and I waiting him in Parma to see the machine and to work together, because we can treat points. We can treat the junction. We can treat. We can get some glass clock effects in the vein, or we can close the vein if you want. So we have a huge opportunities with HIFU. That now we are at the beginning. We are at the beginning of the beginning. even if we did more than 500 cases. But there are many things to do. Another small things I want to spend 2 words about local anesthesia. Local anesthesia, we published the HIFU pain study with 4 groups, and at the beginning, I thought that probably was enough to make intradermal anesthesia to interrupt the nerve, sensitive nerve connection, and we treated some patient with some pain and with not perfect result like now. Now we do 10 cc or 5 or 6 cc of local anesthesia directly echo-guided in the close to the wall. So what you get is a spasm of the vein. So you can treat a vein of 8 millimeters in standing position. In lying position is 5. When you local anesthesia is 3 millimeter of with 1 or 2 millimeter of the of wall. So the energy is delivered very, very well, and we have seen and we published that the results are better with the kind of anesthesia, and the pain is totally zero. That's
Yeah.
that's all for now.
Okay. Well, I know it's your thing about shrinkage and Shiva, and I don't disagree with the idea of seeing what we can do. And as you said at the very beginning of your speech, it's about philosophy. This is a quite expensive treatment for the moment, and it's also about patient experience. As for me, for the moment, with the knowledge we have, okay, I prefer to have ablative and get rid of my vein over the next 30 years, because we know that's the least results we can expect, and not having to undergo again a procedure in 2 or 3 years. But it's just me, you know. If I have to go to the dentist 3 times in a row, I prefer to have an implant and get rid of that. And especially I will say in France, because laser treatments are very cheap, and patients are used to pay a little amount of money for treatment. So I really would have to convince them to completely change their mind. And I already know that I would not have that much patience, but I don't like patience. I have a lot of patience. That's the point. So yes, it's a little bit of a philosophy, but I completely open-minded to evaluate things. You know, we are physicians. We are here to provide the best treatment to our patients according to the science. So for the moment, I just remain in my ablative work, also because I worked so hard at the very beginning of this device.
I know your philosophy, but we have to think two objects. One is money, and the patient will have to pay. And on the other hand, we have the science. We have to move toward the future. We have to move there, because we have to do that.
Gentlemen, I'm going to have to, this is really exciting, but I'm going to have to ask us to move on to Steve Elias for his comments, and then we'll get back to this. There are a few questions that are out, but I think you've really covered them in terms of cost effectiveness and patients paying out of pocket. But Steve, floor is yours.
Yeah, no, first of all, I think there was a great explanation to everybody who isn't as familiar with this, and in general, I agree with everything that both of you have said. And I think, I think there is an opportunity here, which you've already pointed out. Certainly, Shiva, no question about it. I think once we maybe simplify the Shiva technique, I think it's a semi-complicated at this point. When more people can really understand it in a simpler way, I think this is a ideal technology for Shiva. The other thing is, I think you've already pointed out, Guillaume, short stumps, neovascularization, perforators, it's really nice for as well, aside from the truncal veins. And then, Paulo, your study, it was published in Phlebology just last month, your pain study, which was really, I think, excellent, and everybody should take a look at that, because our original study that we did, the pilot study in the US, I did 20 patients, and nobody received any type of anesthetic at all. I wanted to be able to say, this is better than what we're doing now. Patients don't even need a needle stick. However, in the subsequent study, yes, they could have some local anesthesia, and about a third of them wound up needing local anesthesia for pain control, not to necessarily push the vein down. So what I think people really need to take away from this, it's a learning curve. The technology is getting much, much better already. Guillaume, you hinted Theraculon's working on ways of using AI to better visualize the vein. People should understand there's a lot of time initially spent to make sure that where you're aiming is at the vein and not some tissue around the vein. And that requires at times to lift the head off the vein, so to speak, or take the pressure off so you see the vein, put the pressure back on. It took a lot of time for that learning curve. I think we're getting to the point where all of us went through that learning curve, and our experience, along with the changes that Theraculon is making, is going to make it easier for subsequent generations who are going to use this to go much faster. And you pointed out, Guillaume, how much faster it is as you gain experience. I have a question for the two of you, though. Right now, we go 3 millimeters apart down the vein. We walk our way down the vein every 3 millimeters. Do you think the same results could be obtained if we went every 6 millimeters instead, from a hemodynamic and patient satisfaction viewpoint? I kind of think so. That clearly would shorten the time, half the time, or double the length you could treat in the same amount of time. What do you all think about extending the distance between the shots on the vein, so to speak?
I will spill the beans here. That's already what we're doing. I could not explain anything, but we have new goals, and you can, in certain circumstances, treat 2 slices, skip one, or skip one slices every 2 slices. So yes, that's a way to save time. Basically, it's if you are quick enough, you don't let the heating process die. And also, when you move from a slice to another slice, sometimes the bubbles, they avoid you to see the vein, or you shoot inside bubbles and you lose energy. So skipping a slide is better than trying to get each slice treated. Absolutely.
I agree.
Yeah, what do you think, Paolo?
Yes, I agree completely. And in our experience, since 1 year, we don't do consecutive slices anymore. We do alternate slices. And yes, it's better for, in my experience, to treat 5 or 6 spots, even if the vein is not so large. And if you see the next slice, you will see the heat. The image is still like a treated. So is when you treat alternate slice, you reduce the time of treatment of the half.
Yeah. Okay. So no.
Well,
So
I'm gonna interrupt right now because we need to move on. But I think for the whole panel here, the question of cost effectiveness really plays a role. Although I think it's really early to ask that question, but I think it's something that plays on each of our minds, and whether, yes, it's effective, yes, if you select the patient right, but the price of doing business here is expensive at this point. Do you see it changing?
Well, it's a lot at stake. It depends on your healthcare system. As I said here, it's quite cheap to get your varicose treated with gold standard laser. So it really depends on the way you can treat patients and where you live. Remember, laser at the very beginning was very expensive, and they cut down the cost. So yes, it will come. When? I don't know.
Well, the question is, Lowell, is, as you already hinted, Guillaume, it depends where you work. Do you want it to be cost effective, or do you want to, target a population from a business viewpoint that feels that they can pay for a procedure that is less invasive, and it could be an option for them? And I'm not so sure that our goal should be to 100% get this covered by every single insurance company in the world. There may be just
I wasn't inferring that, Steve. What I was inferring was the cost of doing business. If thermal ablation or non-thermal ablation are cost effective, and this one's not, we know. But anyway, I've got to move on. I really appreciate all of this, and I wanted to mention that next week we're going actually to talk about Shiva strategy. And it gives me great pleasure that Dr. Erica Mendoza will be our lead, and then Dr. Claude Franceschi will also be involved. So ladies and gentlemen, thank you very much for your attention. Thank you to Guillaume, Paolo, and Steve, and we'll see you next week. Thank you.
Thank you
Thank
so
you very
much.
much. Thanks
Bye-bye.
Good.
a lot.
Very nice.
Okay.
Guillaume, thank you.
Thank you very much for your invitation.
That was brilliant. It was well done.
Thanks a lot. Thanks a lot. Well. So enjoy your days.
You too. Have a good vacation. And one of these days I'm going to visit. So thank you.